Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Good afternoon to our virtual attendees. We want to thank you for coming to our conversation today, Catalytic Innovation Driving Transformative Change. You might have a question about what growth opportunities other organizations are jumping onto, or maybe what industry leaders are taking advantage of as it relates to technology and how to elevate care without taking the human approach away from it. Well, Axxess, in conjunction with the Council of States as well as the Forum of States, we conducted a survey asking hundreds of care at home organizations just to find out these answers. And the results are in. We wanted to gather each of you today and review our conversation and explore different workforce automations from many perspectives, providing you with actionable insights that you could take away today to create the operational changes that can enhance and improve your margins while helping to scale your organizations. So this particular conversation today is brought to you by Axxess, as well as the Council of State, Home Care and Hospice Association, and the Forum of State Association. Thank you to you both. Axxess is a leading technology innovator for healthcare at home, providing solutions that help improve care for more than 3 million patients worldwide. In addition to that, we are trusted by 9,000 organizations. We offer a complete suite of easy-to-use software that empowers home health, home care, hospice, and palliative providers to make healthcare in the home human again. I am Christina Andrews, the Senior Director of Professional Services here at Axxess, and I will be your moderator today. I would like the opportunity to take just a few moments to introduce our panelists with a short bio. Tim, welcome to our conversation today. We are so delighted to have you. Tim Rogers is the President and CEO of North Carolina and South Carolina State Association. He has over 30 years of experience working in home health, as well as home care and the hospice industry. He received his BA in Political Health Science and History from the University of North Carolina at Chapel Hill. His home care and home health and hospice experience is extensive. Having worked as the first Director of Government Relations and Chief Lobbyist for the Association for Home and Hospice Care of North Carolina, as well as the Vice President of Government Relations for Comprehensive Home Health and Hospice, which is now Liberty, and the Director of Regulatory Affairs and Strategic Planning for Tar Heel Home Health and Hospice of Tar Heel, now Kindred at Home Tortiva. And finally, as the President and Chief Executive Officer for the Association for Home and Hospice Care of North Carolina since 2001. So welcome, Tim.
Thank you.
Evan, welcome again. Delighted to have you, and thank you again for your participation and your members for our survey. Evan Reinhardt is the Executive Director for the Indiana Association for Home and Hospice Care, as well as the Kentucky Home Care Association. He has been a member since 2012, as well as 2018 in both associations. He oversees the day-to-day operation and financial health of the association while managing and lobbying and advocating for the care at home industry. He provides regulatory guidance and support to members and supports his both of his association through team working on behalf of home health hospice, as well as personal service agencies. Evan received his Bachelor's of Arts in Psychology from Butler University and a Master's of Business Administration with a concentration in Finance from the University of Indianapolis, and a Doctor of Jurisprudence from the Indiana University of McKinney School of Law. Welcome, Evan.
Thank you.
And last but not least, Cooper Linton. Welcome. We are delighted to have you. Thank you for joining us. Cooper is the Associate Vice President and Chief Retention Officer for Duke Home Care, Hospice, and Home Infusion. He has worked in the healthcare industry for over 20 years and very, very passionate focus on home and community-based care. He holds a Master in Healthcare Administration as well as a Master's in Business Administration from the University of Alabama in Birmingham, where he also completed his graduate certificate in gerontology. Cooper has worked in the healthcare industry, as I mentioned, for over 20 years, and he has been very focused on community-based care. His background has enabled him to provide strategic planning within healthcare operations, in addition to certificate of need, marketing, business development, and healthcare construction. So he's very well-rounded. His passions around healthcare access for the medically underserved, as well as the desire to enhance access to services for all caregivers. Welcome, Cooper.
Thanks for having me. Glad to be here.
All right. Well, we have talked about this conversation a few times over the past couple of months, and what we want to do is to divide it up in a few different sections. So our first section is going to focus on prioritization of challenges. And as I mentioned, the recent survey of our home-based care providers from agencies of all sizes produced an overarching theme. That theme was to remain viable and deliver high quality of care while streamlining operations through greater efficiencies. However, in that theme, the care at home industry said, we have many challenges that we have to lean into in 2024. As you can see here, statistically, staffing's not a surprise. Changing payment dynamics, as we continue to lean into different APMs, regulatory and audit scrutiny, which is never going to go away, but also employee engagement. What do we need to do differently about well-being? So we're going to talk a little bit talk about that during our conversation today. But before I address the panelists with kicking off our first question, I wanted to focus your attention into this particular element. When we were looking at changing payment dynamics, the regulatory and audit scrutiny, we deliberately asked our surveyors, our respondents, how prepared are you? Like, what does that look like within your strategic planning sessions? If you're thinking about shifting into a new APM, a different type of reimbursement model, the new compliance components and requirements that are coming down the pathway, only 10% of the respondents said they were fully prepared. 10%. That was a bit alarming for us as we were discussing. So that means that 55% were somewhat unprepared, unsure, not prepared, and it really wasn't even on their radar. So I'd like to start off our conversation today, Tim, with you, setting the tone based upon your experience and everything that you do to enhance care in the home. So I'd love for you to take a few moments to speak to the advocacy efforts that correlate with these themes and any best practices that come to mind.
Sure. Well, I can speak from the perspective of state associations and engaging agency members and employees. We're blessed here in the Carolinas that we have a 98% penetration of home health and hospice as members. And so there we put a lot of emphasis on advocacy, not just in Washington, D.C. and not in Baltimore and Atlanta with CMS Region 4, but in Columbia with Palmetto GBA and Raleigh with Columbia with our state legislatures, all of that included. Advocacy is a lifeblood and a major component that runs through any state association, but specifically our state association. And we have a vast array and diversity of agencies. We happen to do all auspices: home care, home health, hospice, palliative care, PACE, behavioral health. Today we're talking about home health. I use the word LRL effect, legislative, regulatory, and legal. And we really hone down on agency directors, administrators, C-suite leaders to allow them to empower their staff to become ambassadors, advocacy ambassadors, to know what's upon us. Look what happened yesterday, a week early, the dropping of the home health rule. That was no July 4th fireworks in our favor. It was fireworks in somebody else's favor. This year has been a year like no other. How many times have we had a trilogy effect of a hospice rule, a home health set of rules, a Medicaid 80-20? I mean, it has been boom, boom, boom. And my old adage is, you hear Congress and you hear CMS and others say, home health is the future. Hospital at home is the future. Home and community-based care is where we need to be. Well, then put your money where your mouth is. and stop being a hypocrite about it. So as long as they're going to continue to cut us, and yesterday's cut was pretty dramatic, which we were kind of expecting, and the clawbacks are kind of expecting, we need to get our employees and our agencies engaged in going to Washington, working with our national now association, our state association. We had our Evan and I and others have software programs and others to engage them in writing letters. We try to make it as easy as possible in order for them to do that. We take it down to the ground level. We also, and my colleagues in other states do the same thing. We find out who's related to a legislator, who's related to a congressman, who goes to church, who shops at a Walmart, who does this, who does that. And we keep a spreadsheet and we utilize that. It's like a campaign. I used to run campaigns when my father was in elected office. It is a campaign, and you have to keep at it and keep at it, not just legislatively, but all these audits that Palmetto GBA and CMS and every other acronym known to man is being thrown at. We're an RCD state that's now going to be extended. So state associations, we're your advocate, but agencies and staff members, you've got to help us to help you. And that's where you've got to be. And besides offering great quality patient care, you've got to be in the know, and you got to know what's happening to your agency. And that's why advocacy is critical.
I love the term advocacy ambassadors. I love ambassadors, but how you pulled that together, Tim. Excellent. Evan, thoughts from you?
So, I mean, I agree wholeheartedly with Tim that advocacy is going to be critical to address some of these issues, and more the request coming from decision makers and policymakers is to hear from those folks at the grassroots level. So that's a key aspect of this. The thing that struck me starting at the bottom, staffing, obviously a consistent issue over the last few years. Payment dynamics, a top priority, as well as the audit scrutiny. Employee engagement, I think that's one that we're really focused on here in Indiana, to try to touch folks through the softer, side of the softer skills, the softer metrics. Let's reach out to folks and try to engage them directly on a scale through the association. So we are putting together what we call our Care Connect sort of network that will create some opportunities for those employees to be engaged and really talk through issues that they're having, whether it's related to work, unrelated to work, and make sure that they stay in the industry. We want to try to avoid that attrition and turnover that we see so consistently. So that's one area. I think Tim's absolutely right. We've got to do the advocacy piece, but we want to see, and we've heard from our members here in Indiana and the operators out there, that soft sort of approach and soft engagement is something that's critical to the employees and the direct service providers out there. So that's an angle we want to try to attack over the next 6, 12, 18 months and see what kind of progress we can make related to recruitment, retention, and overall just satisfaction with being a part of the industry. So we're hopeful to produce some results on that front for sure.
I love the Care Connect, because when I think about employee engagement, one of the connecting anchors with an organization is the fact that they are surrounded by like-minded people. And so bringing them together with that same mission and vision will empower that united voice and create retention ultimately. So brilliant. Thank you, Evan. Well, Cooper, I know you're very passionate about well-being, but we're gonna save that. So I'm gonna hit you up about the alternative payment model component. And before I do, I would be remiss not to highlight the fact that organizations today really need to think about their health alignment with the quadruple aim and any best practices that need to be adopted to ensure they are healthy in each of those aims. I know that you, working with Duke, you have some best practices, so I'd like for you to take a few moments just to lean into this area. What have you adopted and how are you excelling?
So I'll share that alternative payment models are always interesting to talk about because everybody's got a view on what that ought to be, and there's been lots of stops and starts. But I will share that I'll quote Socrates for a minute, because if you're not smart, you should quote somebody who is. The unexamined life is not worth living. Of course, they immediately killed Socrates shortly after saying that, so I hope it goes better for me. The point of this is that you really need to examine your organization and understand it at a granular level, and not, okay, well, I've got 4 stars or I've got 2 stars. I will share that I think there are very few things quite as crude and misleading as the CMS stars. Healthcare has got to be is a lot more complex than a Yelp review. So what is your real data? What does it look like? Your real financial data, true deep cost accounting, not cost report accounting. What is your true cost accounting? You can't go to the table and negotiate for your value if you don't know how to articulate it and calculate it, and also calculate your own costs. And I think most of us in the industry, because of the way we've reported data for years, don't fully understand our own costs and don't truly understand our own value and how to articulate it. That may require that you buy observed data, descriptive statistics from someplace, and be able to run your own analysis. People say, well, that's expensive. Going to the table without knowing your data is a whole lot more expensive than buying the data. I've never found expertise to be the greatest cost. I think it's the absence of understanding that absence of expertise that is where you have an opportunity to really be in a bad position as a negotiator. If you're going to be an alternative payment model and you don't actually understand your cost and your value proposition, what are your outcomes? Can you articulate them? Can you see where the differences are? Do you know the performance of your competitors? It's not just know yours, it's know theirs. This is a competitive environment, and we will all work together in advocacy, but we're all competitors when we're trying to get market share and when we're trying to get dollars from the insurance company. So that's where we've got to invest deeply in knowing ourselves, knowing our competitive environment, and having actual data, not feel-good stuff off of a website somewhere. Our best practices are, we are looking at quality data on a daily basis now. And we can get into some of that as it's tied to our lean practices, but we are literally having daily discussions around issues of quality, patient harm, and staff harm at a senior team level, which is something that most organizations don't do.
Keeps it in the forefront because you're looking at it daily.
I'm sorry, I missed what you said for a second, Christine.
It keeps it in the forefront because you're looking at it daily. You can provide action immediately instead of being reactive because you're reviewing the data daily.
Right. I mean, the data that's published in our industry is often a year to 18 months behind. So it's not realistic for us to have a conversation about how we're going to bend the trajectory of outcomes if we're looking at something that happened a year and a half ago. We have to be in it real time. And if you want to make change, then you can't say, well, we're going to look at this in a report every quarter, or we're going to have a quality meeting and look at your old data once a month. We have to be looking at it every single day. And it also makes it clear what's the priority for the organization.
Yeah.
If you talk about something every single day in your life, it doesn't take long before it becomes a needle that you're going to move because it is your focus.
So how to position yourself at the table instead of being on the menu. Know your data.
Know your data. Well, somebody else is going to know your data. You better know it. You better be able to explain it. Because comparing data between competitors is not as simple as this homogenized, quote, case mix adjusted stuff that comes out from CMS. I would make a strong argument that risk adjustment is very poor. And I would encourage people to work on it, to do their own.
And can I add to that? Because I guarantee you, when Cooper goes with me a lot to advocate on the Hill, And I bet you the staff members in his congressional offices, because he serves multiple counties, are going to ask certain data points of how he stands out in the delivery of home health services. Hospice model, and he's got to be able to bring that data. They used to say for years and years home health industry was so data poor. We just didn't have enough of data to prove our value, and so we just have got to be able to prove our value and to prove MedPAC wrong when we go and sit before members of Congress and their staff members who influence the member. I think that's also a way to take that data, Cooper, and extrapolate it to the good.
Well, have your own data, not just for payers, but when you sit down with a referral source at a hospital, it can't be, hey, we're the fastest and we're the coolest and we have the nicest people in the hospital. Nobody cares. The question is, how successful are you at managing the decompression of those beds? Because that is an access issue for the hospital. How successful are you specific to that hospital at maintaining readmissions or limiting readmissions, limiting ED use? I have never heard a hospital say, I just feel like my ED is underused and I wish more home health patients were coming back to the hospital through the ED. It's not real. So can you walk in not with some generalized CMS data that says our readmission rate is this, but can you go to Billy Bob's Hospital, Duke Hospital, UAB, I'm picking on the places where I've been, and say, what is my readmission rate for your patients at your hospital? What is my use of your ED, and what are we doing to drive that? Whether it's a discussion of remote patient monitoring or specialized care programs, or you're using some sort of triage mechanism to elevate care around patients with high risk for readmission. What are you doing to deliver and prove value and know your math? Because the hospital probably doesn't know.
Well, and I think, Cooper, to your point, it really tees up this next area here, which, in review during our prep calls, we all took a moment and said, wow, this was alarming to us. So when we asked, how would you define organizational maturity, we were looking at two components. One, service quality, and how does that transfer into your financial performance? So leaning back into your point, if they're not looking at the data as it relates to service quality, the health alignment of the quadruple aim, they're not going to have that financial performance that truly is going to enable them to scale. So as you notice here on this slide, only 23% indicated they were able to optimize, that they had high financial cash flow, health within their organization, robust controls, they were detailed forward budgeting and innovative. Whereas the 29% that said it wasn't applicable to their role, I'd love to hear from you gentlemen, what your thoughts are here on these stats.
I'll share the 29% is the one that scares me. If you say, hey, and I'm going to pick on a guy who's middle-aged and overweight, that's me. And I like to refer to myself as middle-aged still, I'm rounding down. So if you say, look, I'm out of shape and I'm overweight, at least you know your condition and you've got an opportunity to say, okay, I'm having an unjaundiced eye and I'm taking a look at it. I know where I stand. Now out of that, I need to take certain definitive action to improve it. That to me is in better shape than the 29% who go, this is not applicable. What do you mean it's not applicable? You're open, right?
Yeah. I hope I'm an optimist by nature. I'm hoping those are the 1 year or less employees that get on the job, or the 2 year or less employees, the ones that have just been, rotated in, from the hospital. I don't know, but this whole idea, this adage of that's not my job, that's not my role. That's a mentality that will not. That's a dog that will not hunt in this generation anymore. It just will not work. It's got to be an inclusivity, and everyone's got to be involved. It's almost the hospice model, interdisciplinary stuff. It's got to be involving people at all roles. Home health can mimic that situation, and that 29%'s got to change.
You know, it goes back, it takes me back in my industry days where sometimes you would tiptoe around the clinical departments when it came to having those financial conversations. We could have the health conversations of the quality outcome, but then financial and sales. But to your point, it's all inclusive. I mean, you know, we need to be that four-legged stool to where you have operations, you have clinical, you have your sales, and you have your compliance. So all sitting on the same stool. Sorry, Cooper, go ahead, Tim.
No, I interrupted you. The toughest job in our industry, in my opinion, is not being the CEO. It's not the CFO. It is your frontline home health manager. And I would make the argument on any given day that that frontline manager that's overseeing a team of home health providers in a body of patients has more financial control over your organization than your CFO does. The CFO is largely in a reporting position, and they're trying to help with strategy and planning, but dollars are spent or made by the people making day-to-day clinical choices.
Yeah, I want to make one other comment. I know the smarter attorney, Evan, wants to say some things too, but I know people are probably saying, well, you're at the association level and all this, but I used to work in an agency in a galaxy far away, but also I took care of parents for 7 years in the home that had everything: private pay, home care, home health, hospice, palliative care, and assisted living for 7 consecutive years. And I almost interviewed every nurse, PT, OT, therapist, and CNA that came in the home. I oversaw all of that from both of my parents who are now passed away. And I would ask them questions about interoperability and intermovement within the agency. I really got to know them a lot. This was not a setup of how they're doing. They all did great. Multiple agencies. So I was able to figure out a few things about that. And I learned a great deal as a caregiver from that perspective on the other side looking in. So that did give me some insight. I wasn't employed by the agency, but I felt like I was a third party press gaining on the outside. So.
Well, and what I would add to that, you know, sort of combining the two perspectives, the association and then to Cooper's point, to get to the granular level, the clinical decisions, and it's even just every decision that folks are making out on the front lines. And we get a lot of anecdotal information from the chairs that we sit in at the association. And it's down to even, you know, a person making a decision to go to Walmart and pick up a script for a patient, and they end up sitting at Walmart because there's a delay and they're there for 45 minutes or an hour. I mean, it's all of those sorts of decisions where, you know, we absolutely want to provide the best care and do everything we can for these patients and families. But it all comes at a cost. And if you're sitting at Walmart just waiting for a script, those are the sorts of decisions that we're talking about, especially given the news yesterday. Much more of that frontline decision making is now going to have an impact on the bottom line. So we need everyone engaged in terms of what is, you know, behavior that's going to contribute to that bottom line, and what is behavior that, you know, is going to cost the agency money potentially. And I know that's always a conflict that we've discussed historically, but to Cooper's point, I mean, that education and that adaptation needs to happen. And to Tim's point, hopefully it is, you know, maybe these are new entrants to the field and we need to engage them and get them to understand how their decision-making impacts the health of the organization. But all of that needs to be coordinated on a scale that we haven't seen to this point, because we continue to be, you know, get that death by 1,000 cuts, especially from the federal government. So yeah, I think all of it's critical.
Yeah. So I love the use of the word behavior, something that I used also a long time ago in sales. Probably should have used it in other areas. I called it the ABCs. So first you have to start with competencies, right? So if you ensure that everybody is competent, it infuses confidence. And then because of that infusion of confidence, that alters the behavior. And that behavior, that forward-facing behavior, is the attitude in which our patients, our families, the care at home industry is going to observe. So we cannot change the attitude, but we can change behavior through education. So anyhow, sidebar. So another thing that the gentleman wanted to highlight today in our conversation really leans into the auditing and compliance as well as oversight. And I think that these particular data elements, really play into the organizational maturity. So when we asked our respondents, how often are you conducting internal auditing? These are the results, so the 22% who don't have it on their radar, they don't have it within their strategic planning, it's disconcerting, because then it's going to play into that overall quality, impacting financial success and the ability to scale. So Cooper, I'd like to start with you here and then pass it to Tim and Evan. So what best practices has Duke adopted to minimize risk in audit scrutiny?
So with some of the technology that we have today, we can actually be running audits on a daily basis. And that seems crazy, but it ought to be a standard work piece for us. And you'll hear us at Duke talk a lot about standard work. We shouldn't have to figure out how to do this every day. We've done it before. So let's do it in a very consistent, very predictable manner. And the creation of that standard work, and we'll touch on this later, is really tied to our lean processes here. And we are auditing on a routine basis. Now, not everything's going to get audited every day. Everything doesn't warrant being audited every day. I also think that, about every 20 years, 30 years, we have some sort of sea change in technology. There's the development of the PC. There's the recognition of the World Wide Web. And over the last couple of years, we've had a recognition of AI. And it's developing at this blistering pace. Now, we see things on the news which are very alarming around AI. We have to think about our social responsibility and how we handle it. But we can take those same tools and harness them for auditing. And I think the future of this is to be less human dependent, less subjectively dependent, and more utilizing and largely dependent on AI to do some repetitive tasks that, frankly, our staff detest.
Right.
It's hard to keep people in certain types of roles. The beauty of AI and machine learning is those pieces of equipment never get tired and never take a day off. And they're incredibly inexpensive to operate. And we're also beginning to play with the idea of using bots for some repetitive work here. But I think we need to look at harnessing technology going forward to fill in some of the gaps that are clearly evident by this survey.
Tim, Evan?
Yeah.
From an association perspective?
Well, I'll jump in from the outside looking in, supporting Cooper, and I'm sure Evan has got some of the same thing. We were a value-based purchasing state, an RCD state, and every acronym known to man state in North Carolina and South Carolina. And so these agencies are doing forced internal audits. They should be, they have to be, in order to compete, succeed, and thrive. And they just have to be. And we've been doing education sessions over and over and over and over again to partner with them, both on the state level, our conference level, our webinar level, and engaging business. We work close hand in hand with all the major business partners and affiliates. We have business partners on our board of directors in both of our states. Axxess is a great business partner, as are others. And so we rely on these people. And also we've done something else for data. Our association has entered into an agreement with Help Pivots, and we're entering into an agreement to get Trella to come to our association more. So those are two big data collecting clearinghouses to help agencies subscribe, maybe at a discounted rate. I wouldn't believe the number of agencies that don't or can't afford. We're going to try to make it more affordable for them through affiliation agreements, through that kind of thing. And so we've worked with our North Carolina Hospital Association, Blue Quality, Patient Pain, and I mean, you name it. Everything I can think of to bring goods and services to our members and to force these internal audits for compliance and oversight we're doing. at least we're making it available.
Right.
It's up to the agencies to take advantage of that at the best way they can. And I know Evan's doing the same thing.
Absolutely. And, I think the 22% is very concerning that anyone either on the payment, reimbursement side or the clinical side wouldn't be taking a look at what's happening internally. So in Indiana, one of the more stringent states from a survey perspective, frequently discussed how we're an outlier in terms of immediate jeopardies, and plans of correction needed, and on and on and on. So particularly in this kind of environment, we would advocate for folks to be looking at what's happening internally much more frequently, and staying abreast of what's happening from our Department of Health here, what new perspectives and interpretations they have of rules. Sometimes they come from CMS, sometimes that come internally. Both of those need to be kept up with as frequently as possible. So, I think to both Cooper and Tim's points, like we have to boost that up and do what we can on an ongoing basis, whether that's through automation or just more frequently looking at the more subjective pieces, so that we can ensure that time, because again, we're back to the bottom line here. This is not reimbursable time that we're discussing. So you're going to cost your agency if you're not up to speed and where you need to be.
Yeah. So my takeaway before we transition into the next area is, the consideration for budgeting perspective. What needs to be true within the budget to support more internal audit to reduce the risk? All right, so we're going to transition into the next section, which is the respondents indicating the areas of opportunity for improvement that really will impact their bottom line. We've talked a little bit as it relates to those challenges, and I know that we've highlighted data, we've highlighted external data, internal data to really help to optimize. But we haven't talked a lot about market share from a challenging perspective. So Cooper, as it relates to focused areas within Duke's operations, what are you considering, what are you utilizing as it relates to best practices to drive overall growth?
Well, I think one of the slides you showed earlier was that the number one consideration everybody had was staffing. At the end of the day, for us, staffing is also inventory. You cannot grow what you do not have. You cannot sell that which you do not have. And human talent is what we keep an inventory of when we hire. And when we, you mentioned, you introduced me as the chief retention officer. Interestingly, I want to be clear, every single person in our organization is a chief retention officer. Every member of our leadership team has that in their signature line, because we are in the business of attracting, training, retaining, and maximizing talent. And if you don't have that element, you can have all the opportunity for market share, but you have no capacity to actually obtain it. And then if you do go after that market share and you've not trained those people, to your point earlier about competency and therefore the associated confidence that emerges from that, you're not going to deliver a sustainable quality, nor will you have anything that you can share as outcomes, be that to larger referral sources or to payers. So for me, this 100% starts with people. And when we talk later about some lean processes, if we win the people conversation, we can then get into how do we optimize scheduling, or how do we minimize the friction costs associated with billing, or shorten revenue cycles, or reduce write-off. We can have all of those conversations after you have talented people delivering care.
Yeah. And if I could add on to that, if it's okay, I can tell you from our perspective, what an association can do for its members. And this is a little plug, and I'm real proud of this. And for 4 years during the pandemic and after, we received a $500,000 grant nursing onboarding and mentoring nurses directly out of nursing school into home health and hospice, because we were seeing a dramatic amount of retiring home health and hospice nursing at age 50 and 55 and not coming back. Too young to retire is what I thought. So we went to work with the North Carolina Board of Nursing to get their support, and all community colleges and universities, and we worked with our agencies to become preceptors, and we started seeing direct hires after they went through a number of programs and everything, using that money through the grants we got here in North Carolina. And some of our home health and hospice agencies 3 years later have these nurses directly employed with them still, and are some of their best performing nurses. And there was a newsletter written up about it, and I was real proud that we won an ASAE award for that program. And we're trying to continue that on the CNA level now, where there's also needed in both North and South Carolina. We also recognized, in order to for retention and recruitment, safety in the home and safety for the employee is a big thing. So we started working with companies like Katana Safety, because we have all heard about the tragic situations of nurses who've lost their life or whatever to domestic violence in the home. And so we were able to work with some large health systems to get those badges that those nurses have, that were able to recognize, where they were able to push for emergency situations, to get the nurses and others to feel a little bit more comfortable. And we were able to push with that, an affiliate program with our agencies. And also, when you're able to introduce more business partners, and Evan does this too, that brings in scheduling software and operational things to make as much introduction to agencies to be able to optimize their bottom line. That's what an association does. That's what our colleagues try to do for our members, to offer to what Duke is doing to the best that they can do. We're trying to do it as well.
And taking that one step further, and Cooper, you and I had kind of passed this message along on one of our previous calls related to the presentation today. So staffing, absolutely, and recruitment and retention, top priorities. And then secondarily, we've gone from kind of a volume to approach to a payer mix approach, and being strategic about your payer mix related to your market share. That's much, much more important these days than it ever has been. So, Cooper, I don't know if you have anything to add, just more details there, but we hear that message loud and clear from our members.
Well, I think it's an incredible point that you're bringing up, Evan, because the payer mix is key. And for an organization like ours, whose primary mission is to decompress the Duke Health System hospitals, that's what we do. So we take a payer mix that nobody else wants. By the way, if any of my competitors would like to have a slice of our mix, I am more than happy to provide it. The reality of this is that your payer mix has more to do with your health than your actual volume. And then I mentioned earlier, you've got to know your costs, not your Medicare cost report costs, your true operational costs, and they are not going to be the same by payer. There are payers that have a much higher administrative burden associated with them, a higher carrying cost related to revenue cycle associated with them, and those that have a higher likelihood of bad debt associated with them because of, let's say, some onerous payment policies where they are strongly incentivized to deny. So if you don't understand those true things, and you're only looking at your cost per episode, or excuse me, your revenue per episode by payer or revenue by visit payer, without understanding the diversity of cost by payer, you only have one side of that equation. And so your financial health and your ability to invest back into your own organization is limited by not understanding at a deeply individualized level the value of each payer and the impact on your organization.
And that's at every stage. I mean, so new entrants to the industry, they're going to struggle with the contracts that they're being given by Medicare Advantage, just into the network. That's going to be a challenge. And then folks that have been around for years and years and years, to Cooper's point, it's are we getting paid what we think we should get paid? Where are we with negotiation as far as reimbursement, and how many of their patients do we have currently, and will we be taking in the future, regardless of which plan it is. So I think it's a critical piece of the equation here that has really just, the staffing component's so huge, recruitment and retention so huge, but this one's right underneath that in terms of health of your organization, I think.
Yep. That old adage, if you're not growing, you're dying, right? So you need the market share. So I think this transitions us really well into our next area here, which is about employee well-being. So as you all take a look at this slide, which I'm going to talk about in just 1 second, I really want to set the stage of that overall growth. Right now, our U.S. population is older today than it ever has been before. We have 10,000 U.S. citizens that turn 65 every single day. That's crazy. It's just, so if we're going to bridge that gap of having the employee to say yes, negotiating the best rate so we can deliver the care, high quality care at a cost that we can absorb, we also need to understand that the kind of the sweet spot is patients between the age of 75 and 85 are going to be utilizing our care at home services at the highest rates. And that is going to continue to grow over the next decade. So the population of 85 and older, not to be Debbie Downer today, but it is projected to double from where it was in 2016, from 6.4 million to 14.6 million.
Right.
That's 129% increase. Now, Tim, Evan, Cooper, I'm sure you've seen some statistics that have come out as it relates to retention. We're still seeing retention, but there has been a little bit of, like an uptick in retention. I think it leans more into the hospital sector, not as much so in the care at home sector because of the bonuses that they're offering. But we all know in the care at home industry, we can't even compete with those bonuses. Sure. So this is one stat that I want y'all to walk away with, and it's not on the slide that I have up. And this is crucially important, and I'm going to turn it over to the panelists here in just a second. 75% of our workforce in 2025 will be made up of millennials. And thereafter, the generations thereafter. So when you think about millennials, this is a completely different soapbox, but the most important consideration for an employer of choice is the ability to upskill themselves and to have that control flexibility for a gig economy. They want to either climb that career ladder. So what are we doing as it relates to their well-being, utilizing technology to enable them to climb that career ladder, or what are we doing to support that control flexibility of the gig economy? So this is where workforce well-being really comes into factor, because only 1 in 4 employees today state that their organization truly cares about them. And if we truly care about them, these are the stats that you will be able to report as you think about, and I'm pointing to my other screen here, but that you will be able to report as you think about overall recruitment and retention. So well-being is a huge, crucial factor for organizations. So now, when we think about well-being, technology needs to be an extension of the workforce. And I know Cooper is very passionate about this. It's not to replace, and so is Tim and Evan. It's not to replace the workforce, but how do we create the ability for burden, less stress, allowing them to work at the top of their license, to get that skill set that is needed. So when we ask the respondents, how are they leaning into workforce well-being through the use of technology investments, this is the outcome that we actually saw. So I was very happy and delighted to see this. So when we break it down into 2 components, we got the technology investment and the return on technology investment. And you will see in both of these areas engagement. So we are starting to recognize more and more so today how technology plays a crucial component. So Cooper, I'm going to open up with you again because you're wearing the shoes every single day, and then I'll pass it over to Evan and Tim. But as I mentioned, embracing technology, it really helps to provide that support. And I know that Duke has incorporated some lean processes to assist with this. So you have the floor, my friend.
Let me jump in with a thought. You started with the bonuses. And I think if we're not paying people competitively, money matters.
Right.
But money, you're never going to pay somebody to be miserable every day. You can't pay people to come to work. And I think that's even more pointed for the millennial generation and your Gen Z generation, who say, look, the money isn't the number one thing for me. So yes, we need to be competitive. We always need to be in market, but those are table stakes for showing up every day.
Right.
Where we have an opportunity to distinguish ourselves goes back to how we treat our people. And we need to take ownership in them. They are not just staff. We refer to, I don't like these generic terms for folks. We struggled, and let me share, and it's a painful story for Duke, but we had really difficult turnover several years ago. And go back to that unexamined life concept again. We did a deep dive into what we were doing versus what we were saying. We said we valued people, but the technology that they were being asked to use did not respect their time. And what I meant by that, it was inefficient. And because it was inefficient, we were asking people to work late to do documentation, to impact their work-life balance, to be entering documentation in the parking lot while their kid was playing ball. That doesn't sound like we respect them. So we took hard looks at our internal processes, and we've also made changes in those technologies to include 2 EMR changes in the past 18 months, which is a massive undertaking. I wouldn't recommend doing it every 18 months, to be clear. But we did a deep dive into what our processes were, and then with the assistance of a group that came in with lean technology, put in a set of huddles that we use every day. We start with our frontline staff, and we ask them to identify the barriers that they have. Our job is then to prioritize the removal of those barriers immediately, not in 2 weeks at a senior leader meeting, not at a quarterly retreat, today. With the urgency that says these barriers, be they technology, be they an inability to access supplies, whether it's an inability to access leaders in time, these elements are impacting their work life right now. And if we're not moving with a sense of urgency, what we're telling them is, you really don't matter to us. Mm-hmm. And they hear that not because of what we send out in a newsletter, but based on the way they're treated. Now, in the period of time, we've cut our turnover by 50 to 75% in these programs, which is a massive, and some of that in as short a period of time as 6 months. By taking a deep dive into understanding why people are leaving, and I don't mean just an exit interview. I'm talking about getting in the place of work, the Gemba, as we say in Lean. Get in there and understand what these people are experiencing and ask them what's going on. And the only way they're going to answer you truthfully is if they trust you. But if they trust you enough to tell you, you better stop your world and fix their problem. Mm-hmm. Because they're going to otherwise have a referendum on trust.
Mm-hmm. A referendum on trust. I like it. Yeah. It's
when they leave, that's what they do. They have when they leave your organization, it's a referendum on your leadership, your culture, and their trust. And if we can address those 3 things, we can run world-class organizations, because world-class people want to deliver world-class care, but we can't treat them like they're a commodity. Like the next one is waiting to fill their position tomorrow, and 3 days of orientation later, we can give them a bag and a map and they're going to be fine. They're not.
And before I open it up, Tim and Evan, for your final thoughts in this area is, the employee value proposition is so crucial. And so when you think about your employee value proposition, that is your promise. your promise to the employees that you are caring for today and hiring into the future. So EVP, as we like to call it, employee value proposition. So Tim, Evan, any thoughts within this area and how technology enhances employee well-being?
Yeah, I think Cooper did a great job of getting to that granular level and then zooming out from a statewide perspective. We're looking at opportunities where at scale we can deploy some workforce development consultants to try to address. So there may be a time, to Cooper's point, you have to develop that trust to hear what the problem or obstacle the employee might be facing. And there are times maybe where they wouldn't tell you or wouldn't necessarily, have that kind of rapport developed. So we want to deploy some folks that are, working in partnership with the agencies, but are not agency representatives, to go out and engage individuals and see what their needs are, whether that's housing, food, electricity, utility bills, etc. Whatever their needs are, we want to try to find the right resource to address that need, whether that including a lending program for folks that maybe don't have the credit that they might need to have to otherwise get traditional lending services. All across that gamut to try to find resources for folks to address whatever obstacles they're facing. Again, sometimes internally, sometimes externally. Pay rates are definitely something that's a priority, and our state has done some strategic, really investigation into the needs of the direct service workforce. Pay rates is a top priority there, but there's a ceiling in all of our, major payers with Medicaid, Medicare. So we want to try to get to some of those, secondary, tertiary issues that, transportation, childcare, all of those sorts of things that we can help have an impact. So we'll be doing some things on a statewide basis and looking to our members to participate and grow that, hopefully having kind of a statewide coverage for a network that, again, hopefully we can copy and paste in other states. But that's also, back to our point about agency health and the value proposition, that these are also things that we hope can help with agency productivity, so that we can take on some of those burdens and help find resources for folks, as opposed to agencies internally, not that they wouldn't want to or don't dedicate that time, but if we as the association can find a way to help move that needle and do it in a way that keeps the employee very happy and satisfied with where they are, that's an ultimate objective of ours. So we'll be sending out some information on that. So and again, we hope to take it nationwide with some of our partners. So that's one thing we're looking at here in Indiana.
Yeah. So Evan knows that the Council of States is really good at sharing ideas and copying that. So I'm copying that from Evan. But also, Evan and I've talked about stuff like this before, and we are doing some consultants to come in at various levels, including spiritual consultants and those that are also can help people with their mental health and physical health. And all of that, agency-wise, our foundation has been doing this for several years and will continue helping employees during hurricane relief efforts. We've paid CNA car bills, grocery bills, gas cards. We've raised money for that. We've done thousands and thousands of dollars when they've lost everything, when they were trying to make visits to patients while they didn't have any lights on and things like that. So that's all about recognition and support. That's something our association, we're very proud of that we've done for agencies. It's all about giving back. And we're listening, we're survey monkeying our agencies about what they want to talk about with technology and engagement, and then using it at our annual conferences. And the final thing I want to say is, I needed to put my money where my mouth was. I'm the son of a psych nurse. So during the pandemic and after, I instituted my own program for my 10 employees. It's called HEART, helping employees achieve reaffirmation and a thank you. And I worked with all of my employees to find out what were their needs during the hybrid time and the Zoom times, and physical, mental, what was going on with their family, what was going on with their work life. And then they got a chance to choose a program every year that I either gave them special time off, we donated a little bit of money, sometimes personal money, to a charity of their choice in their honor. We had an employee had a new grandchild. We sent her off for 3 days to go visit that grandchild without having to use PTO. You wouldn't believe the number of little thank you notes you get back and things like that. But it's showing that interest and that engagement. And I never really thought about it on the 10 employee level and an 8 employee level. And it was even more than that. It was some very emotional things that I did for some people that would talk about privately. And it was very appreciated. And I think agencies have done the same thing, just listening and asking me, how are you doing? How's your mom doing? How's your dad doing after surgery? And things like that. It goes a long way. It's called We Care.
I love it. I love it. I love it. So with our 30 seconds left, gentlemen, what is the one takeaway, the actionable insights you would recommend to our virtual audience today that they need to consider to optimize?
The first thing that comes, sorry, go ahead.
No, you go ahead, sir.
This is going to sound hokey to some of y'all, but I mean it from the bottom of my heart. You do not have to like all of your team. You do not have to like all of your employees, but you do have to love them. You got to love them and take care of them because you love them.
I'm going to say two things based on my staff and then what the agencies. When my staff gets a call from a member about a regulatory question or a technical assistance question, I tell them, or an email, I tell them it's not about the member. On the other end of that line is a family. It's a patient. It's a child. It's a hospice patient or home health patient. And that's who we're working with. For the agency, stay engaged, stay informed, and stay as an advocate and work with the agency to work with your association. I am biased, but we're in this together, and we truly are trying to help you, to help us, to help get this world a better place. And it is about that family and about that patient and that client.
And I would just echo the engagement. I mean, engagement and advocacy, engage internally with your employees, related to that retention effort. And likewise, financially, the bottom line. I mean, gone are the days of we can worry about that payer change in 6 months, or we can just get focused internally. You need to have that engagement externally, internally, and even down to the micro level. That all has to happen.
Yep.
And we've got to raise all boats along those lines.
Yeah.
Well, thank you, gentlemen, so much today. This conversation has definitely, I have notes, even though I've talked to you quite a few times, this conversation has definitely provided actionable insights to elevate the care at home industry. So I cannot thank you enough. Our gift to you, virtual audience, you will see in the handout, we have provided practical, actionable insights for your takeaway and how to optimize them within your organization. So thank you for joining our conversation today. Everybody be well.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.